Hello, everyone. I'm Rafael Madero. I'm one of the chief residents at Mount Sinai Morningside West, and I'm going to give you a brief overview on tumor lysis syndrome as part of our HEMONC emergencies curriculum. So we're going to start by the definition. So this is a potentially life-threatening emergency that can develop rapidly after the lysis of malignant cells, resulting from an inability of homeostatic mechanisms to respond to rapid release of intracellular contents. There are also some animal models that suggest a detrimental effect on the microvasculature by emboli formed by some of this intracellular, nuclear, and cytoplasmic debris. And this is just a slide that I found in a review article in the New England Journal of Medicine, as you can see below. This is just to give you a big picture kind of review, and so that you can understand the condition a little bit better. I'm not going to spend too much time explaining it. You can pause the video if you feel it is helpful. Basically, like we mentioned, you have lysis of cancer cells, and this leads to release of intracellular contents, including DNA, electrolytes, and cytokines. This in turn causes, acute kidney injury, cardiac arrhythmias, and other conditions that we'll go into a little bit further on. And, we also have here the accumulation of uric acid from the breakdown of DNA. And you also have the areas where allopurinol and respirocase act. And as you can see, with urinary excretion, that helps prevent tumor lysis syndrome. Most of these intracellular components are excreted through the kidney, but when there's accumulation, that's when you have tumor lysis syndrome. And so, what is the emergency? Why are we talking about this? Basically, it can lead to organ failure and death. It is something that is potentially preventable with adequate identification and treatment. And with like we said, this condition depends on the lysis of tumor cells. And with newer therapies that are more cytotoxic, more effective, you have a more rapid death of cancer cells, and this increase has been increasing the risk of tumor lysis syndrome developing in tumors where we might not have seen this condition before. In terms of the diagnosis, so you have the lab abnormalities. So you have hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. Hypocalcemia is not caused by the release of intracellular contents directly, but it's an indirect effect of the high phosphate levels. And as part of a clinical presentation, you have acute renal failure, cardiac arrhythmias, and seizures. The diagnosis requires two lab abnormalities and one of the clinical presentations. And of course, this has to be within a specific time frame of starting chemotherapy. Usually it's like 3 days before to 7 days after. You can have also like spontaneous tumor lysis syndrome and other conditions, but we're not going to get too much into that right now. And some talking about the risk factors. So, renal dysfunction, because like we said, this is something that is renally cleared, hyperuricemia, hypotension, and high tumor burden, particularly associated with ALL, AML, Burkitt's, multiple myeloma. You also have some other tumors that are rapidly dividing in talking about solids, such as small cell lung cancer, melanoma, some types of inflammatory breast cancer, germ cell tumors, and liver metastasis and overall tumor burden, organ involvement can be involved with increasing the risk factors for tumor lysis syndrome as well. Like we talked about, tumor response to treatment, hypovolemia, and urine acidity, because an acidic urine increases the risk of uric acid precipitation. And so we talked a little bit about how it's preventable. So you can pre-treat the high-risk patients. Like we already mentioned, some of the conditions that make tumor lysis syndrome had like patients have a high risk of developing this condition. And so these patients, you give them IV fluids, you should aim for a goal urine output of approximately 2 cc's per kg per hour. You can use uric acid reducing drugs if necessary. You should send testing for G6PD deficiency. Because this is a contraindication for respiratory. Of course, it is also contraindicated in pregnant women. We're going to go a little bit more over the treatment options in a little bit. And in terms of the urine output goal, you can also use Lasix as well to keep a high urine output. Now, talking about treatment, I tried to make this table to summarize some of the key components of TLS management and some of the typical clinical presentations. So you have hyperuricemia that can present with joint pain, altered mental status, and AKI. Treatment for that, besides adequate hydration to avoid crystal precipitation, and what we have already mentioned that, keeping up with the urine output. You have some of the agents that you saw in the earlier slide, given an overview. You have respiratory, you have allopurinol for respiratory. Don't forget to get your 6PD. And respiratory is extremely effective, very expensive. Allopurinol is not as effective, but it's cheaper. Why is respiratory better? It's because it's an enzyme that basically helps make uric acid more soluble by turning it into allantoin, whereas allopurinol only prevents formation of new uric acid by inhibition of the xanthine oxidase, and that's why respiratory actually clears the uric acid faster. It's just, like I mentioned, pretty expensive. Hemodialysis is the last resort. For hyperkalemia, this can present as muscle weakness, cardiac arrhythmias, including sudden death, and you treat it as you normally treat hyperkalemia. You have insulin dextrose, albuterol, calcium gluconate, and hemodialysis as a last resort. You also have loop diuretics, which in turn can help you keep up with the urine output a little bit. Feel free to give fluids and diuretics at the same time. This is one of those conditions where no one is going to blame you for doing so. And Kayexalate and other SPS agents can be used, but they take a few days to actually have an effect. So don't make that your sole treatment, especially if you're having active TLS. And of course, they are also associated with some rare side effects such as bowel necrosis. And telemetry monitoring is necessary if the patient is having TLS, because of this risk of hyperkalemia and association with cardiac arrhythmias. Hyperphosphatemia can cause nephrocalcinosis, cardiac arrhythmias, partially because of calcium phosphate deposition. And the management for that, since it's basically low phos diet, phosphate binders, adequate hydration, since we mentioned, it is renally excreted. Hemodialysis is the last resort. Hypocalcemia can cause neuromuscular irritability, cardiac arrhythmias, and seizures. Since we mentioned, it's an indirect effect caused by the hyperphosphatemia. The main management of hypocalcemia is management of hyperphosphatemia. You can give calcium gluconate just with caution, since there's a risk of calcium phosphate deposition. So just give enough calcium to treat the symptoms of the patients. Some of the general measures for active TLS or high risk TLS, it's 4 to 6 hours. You should really be getting lab, especially in renal impairment. Follow hourly urine output. So consider ICU care because of these things, and the telemetry monitoring. If your patient is at intermediate risk, you should be getting labs every 6 to 8 hours while getting treatment. If the patient has low risk, you might still want to get labs every 12 hours. And for some of the take-home points, basically know the risk factors so you can identify TLS. We talked about some of these conditions, and pre-treat if the patient is high risk. Hydrate, give uric acid lowering medications if needed. Look for it in the labs. Check K, phos, calcium, uric acid. Remember, the phos is not included in BMP, and uric acid you'll also have to order separately, and you might also want to get an LDH to just to look at tumor burden. and treat accordingly and know when to escalate care. Like we mentioned, when to get crit care involved and renal involved as well. These are just some of the references that I used to make this presentation. Hope this was useful to all of you, and feel free to reach out to me if you have any questions.